I just want to say hello and good evening. Thank you all for joining us for our 5th Living with Liver Disease session. My name is Carrie Furnell and I'm the Development Coordinator here in Alberta, and I'll be the moderator and host for this session. I'd like to start by acknowledging that the Canadian Liver Foundation's national office in Markham, Ontario is situated upon traditional territories of the Anishinaabe peoples of the Haudenosaunee peoples, covered by the Upper Canada Treaties. The CLF's Living with Liver Disease program's been around for more than 25 years, and it continues to serve as an educational tool for both patients and caregivers, but also as a peer support tool. This program provides an opportunity to increase community-based learning about liver disease and the importance of liver health in hopes to reduce the incidence and impact of liver disease through prevention, early diagnosis, treatment, and care without geographical barriers. Speakers include healthcare providers, allied health professionals, subject matter experts, as well as patient advocates. So to get a better idea of who our audience members are today and where they're tuning in from, we'll open 2 short polls that will pop up on your screen. We'll give you a minute to go ahead and do those polls. Nim, I'm not seeing any polls. Are there polls? Does everyone else see them?
Yes, most of the audience was able to complete them.
Okay. Okay, then I'm going to carry on. Today's session is going to address children's liver disease. We're joined by our presenter, Dr. Simon Lamb from the University of Calgary, and our patient advocate, Michelle Vanderhart. We'll have 2 speakers complete their talks prior to moving to a question and answer portion. Please feel free to use the chat feature at the bottom of the Zoom screen to ask your questions during the presentation, and note that questions will be answered following the speakers' presentations. Following the Q&A, we'll be hosting breakout room sessions. This will provide an opportunity for our community members across the country to talk about their journeys openly and safely, share insights, stories, tips, and suggestions with others who may be going through the same thing in their respected local, regional, provincial area. For those who are not familiar with breakout rooms, it's a feature within the Zoom platform that allows people to be split into smaller groups within the meeting. The groups are split into regions or provinces. We'd suggest joining the group that best fits your geographical location. If you find yourself not sure which group to join, one of our moderators and staff members will assign you to a group. The big breakout rooms will be running for about 15 to 20 minutes. Today's session will be recorded and available on the Canadian Liver Foundation's Living with Liver Disease webpage. That's www.liver.ca/LWLD, as well as our YouTube page in the coming days. In respecting our members' privacy, the breakout room sessions following the talk will not be recorded. For those of you who are new to this program and may not be familiar with the Canadian Liver Foundation, the CLF was established in 1969 and was the first organization in the world created to help people with liver disease. We are committed to promoting liver health and improving the prevention, diagnosis, and treatment of liver disease through our 4 core pillars: research, education, patient support, and advocacy. At this time, I'd like to welcome our first speaker, Dr. Simon Lamb. Dr. Lamb is a liver specialist and clinical assistance professor at the University of Calgary. He returned to Alberta Children's Hospital after completing a transplant hepatology fellowship at the Cincinnati Children's Hospital Medical Center in Ohio. He previously trained at the University of Alberta for medical school and the University of Calgary for his pediatric residency and gastroenterology fellowship. Dr. Lamb's clinical expertise includes caring for children with chronic liver disease before and after liver transplantation. His translational research focuses on understanding the mechanisms of disease progression and biomarker discovery in children's autoimmune liver diseases. Dr. Lamb, the show is all yours.
Great, thank you. So I'd like to thank the Canadian Liver Foundation for giving me this opportunity to talk about this topic that's near and dear to my heart. And then thank you to all of you for coming to this talk and sharing a bit of your time with me. I'm just going to share my screen. This will stop. I'm going to share my screen. So hopefully you guys can see it. And just by kind of looking at the participants, I feel like I probably know at least some of you guys. And then for those that I haven't met, my name is Simon. I'm one of the pediatric liver doctors at the Alberta Children's Hospital. I've geared this talk mainly towards biliary atresia, mostly because it's one of the more common reasons that patients with liver disease get a liver transplant. And then also because our patient advocates, her child has biliary atresia. But I am happy to answer questions related to other types of pediatric or childhood liver disease sort of in that Q&A. So if you have any questions, please feel free to save that until the Q&A portion. My outline is pretty straightforward. We're going to talk a little bit about background of what biliary atresia is. I think most of the people here have a pretty good understanding. We'll discuss a little bit of pathophysiology or sort of what causes biliary atresia. We'll talk about screening. And the reason for this is important because this is something that we are currently working on as a province. So I'm partnering with colleagues in Edmonton to try to come up with a robust screening program specific to Alberta. Some post-op considerations. So after the diagnosis and after the surgery, which we'll talk about in a minute, like what do I look for to see if the surgery is working or not, and then sort of future directions and sort of clinical trials that are ongoing currently for patients with biliary atresia. I'd like to mention that I have no financial disclosures. So what is biliary atresia? So this is sort of a general picture of what the liver looks like. As everyone knows, the liver is an organ in the right upper quadrant. And inside the liver, the way I think about it is that we have these bile ducts. So that's sort of highlighted in this green sort of pipes in this cartoon. And what the bile ducts do is they drain bile out of our liver. And so I think of these as pipes. So you have pipes inside the liver and then pipes that kind of come out the liver and then join into this common bile duct. And this pipe drains all the bile into our small intestines. And the reason our stools are colored, so either green or brown, is because of that bile getting into the small intestines and then being metabolized by the bacteria. And that's why our stools are colored. And so normally, as I said, the bile that's from our liver comes through these pipes or these bile ducts, first from inside the liver and then out of the liver into the small bowel, which pigments our stool. In biliary atresia, there's a blockage of the pipes outside of the liver, and as you can see here, the bile can't go through those blocked bile ducts, and then they come out of the bloodstream or leak back into the bloodstream, and that's what causes jaundice. There's sort of a couple of different types of biliary atresia that I think about. So this is sort of the normal picture where the pipes are nice and can drain into the small intestines. You have several different types, and it doesn't, for the purpose of this talk, really matter in terms of what type you have, because the surgery is basically still the same. But there's kind of three subtypes of biliary atresia where the pipes outside the liver are scarred down or blocked. And so in patients with biliary atresia, because the bile can't be removed or excreted outside of the liver, then the patient's stools become very pale or white. So this is sort of a typical picture of a patient with acolic stools or unpigmented stools. You can see that it's quite pale and abnormal looking. The incidence of biliary atresia is quite variable. So in the literature, it's sort of quoted between 1 in 8,000 and 1 in 20,000. In Canada, we're closer to the 1 in 20,000, but in Asian countries like Taiwan, it's up to 1 in 5,000. So it's actually quite common in Asia and a little bit more uncommon in Canada. As I said, it's a little bit more common in Asians and more common in females. And there's sort of two main categories of biliary atresia. So there's this embryonic type, or BASM, which stands for biliary atresia splenic malformation. And we think about these patients in that their injury or their development of biliary atresia probably happened while they were still in utero or inside the uterus. These patients tend to have some, could potentially have some cardiac issues or some issues with their spleen and other sort of congenital defects. Whereas 85% or the majority of patients with biliary atresia, they have this sort of postnatal type, which we think that sometimes they have normal kind of looking stools, and then as the disease progresses, then become more and more acholic, kind of like this picture. And as I mentioned before, biliary atresia is the most common reason that pediatric patients require liver transplant. So they actually account for 50% of all pediatric liver transplants worldwide. So what causes biliary atresia? So the short answer is no one really knows, but we think that there's probably a genetic component. Some genetic studies have identified genes that may play a role in either the development of the bile ducts or predisposed injury to the bile ducts. There may or may not be a virus or some sort of toxin or some sort of vascular insult while before the baby is born that might be affecting how that bile duct develops. And then after the delivery, we wonder if there's still those viruses, toxins, or vascular insults. But then also we wonder if there are sort of developmental susceptibilities. So that means when the bile duct is formed, are the bile ducts, number one, normal, but then number two, do they function appropriately? And if they're not functional appropriately, or they're not lined by the appropriate type of mucus, then could that increase their susceptibility to a virus or a toxin insult, and then this causes inflammation and then eventually fibrosis, causing the phenotype of biliary atresia. So as you guys know, when we do the workup, oftentimes the patient presents with jaundice and pale-colored stools. We often do a liver biopsy, but ultimately it's this thing called the intraoperative cholangiogram that helps us make a diagnosis. And basically what that means is the patient is brought to the OR and a needle is inserted into the gallbladder, and then dye is injected through that needle. And if the biliary tree is normal, we would expect normal communication between the gallbladder, which is outside of the liver, and the pipes that lead into the liver. So sort of inside this red circle, you can see that when the contrast is injected, you could see that there's an outline of the biliary tree inside of the liver. So that's sort of what we would expect to see in a normal patient. In patients with biliary atresia, because those pipes outside of the liver are scarred down or blocked, when we inject dye into that gallbladder, you can see here that nothing inside the liver lights up, so you don't see that tree at all, but you do see drainage into the small bowel. So because the dye isn't able to get into the liver, we know that those ducts or those pipes outside the liver are blocked or scarred, so that's how we actually make the diagnosis of biliary atresia. So during the surgery where they make the diagnosis, if the diagnosis of biliary atresia is made, then there's something called the Kasai portoenterostomy. So basically what that means is the pipes outside the liver are cut down and replaced by a piece of this intestine. So this brown piece is the intestine that they go to where the bile duct should be draining out of the liver, and then they reconnect the bowel that comes from the stomach to a portion a little bit further down. So this is sort of a makeshift pipe allowing drainage out of the liver back into the intestines. And the way that we know if the Kasai procedure worked or not, or one of the first things that we look for, are pigmented stools. And so I'm putting this warning on here because there are poop pictures sort of coming up. So before the surgery, we have this stool where it's very pale, very acholic, as we would describe it. And then after the surgery, one of the things that we look for is then does the bile get excreted? And so we're quite pleased when we see that the stool become pigmented or colored kind of like this. So for biliary atresia, what's been the Canadian experience? And so this was a paper that was published in the Journal of Pediatrics back in 2017. So this was a cross-Canada study with a number of pediatric liver doctors sort of throughout Canada. So they identified about 350 patients in two eras, so between 1985, 1995, and then 1996 to 2002. They found that the median time of Kasai, or that procedure, was around 55 days. And that's important because sort of in the literature, what's been the rule of thumb is that patients generally do well if they get their surgery before sort of 8 weeks of life, so that's kind of like that 56 days. So, when I was going through medical training, we were always striving for, we want to make sure we diagnose and have the patients undergo their surgery before the 8 weeks. And then they followed these patients for up to 70 months. And what they found was that, patients with biliary atresia tend to do okay. So, the 10-year survival is about 75%. But they also found that at 10 years, about 80% of the patients had received a liver transplant. So, and that's in line with other countries in the United States and the UK. Like that's generally what we've seen, and in Canada is no different than that. What they did find that was quite interesting and a little bit new was that in patients that had their Kasai procedure done before 30 days of life, they were able to show that a significant portion of these patients were able to survive with their native liver, so meaning that they did not require a liver transplant. So as you can see here, in patients that got their Kasai procedure before 30 days of life, this is what that solid bar is. About 80% of them still had their native liver by 2 years of age, whereas patients that had their Kasai procedure done at older than 90 days of life, they had only about 30% of those patients had their native liver at 2 years. So about 70% required transplant by 2 years of life. So really what this paper showed was that the earlier you get your Kasai, the longer that you could probably survive without getting a liver transplant. So then that brings us to our next topic is, well, screening. So how can we detect biliary atresia earlier in babies? And so there's been a couple of different strategies. So we'll talk about the stool cards. They've had quite good success in Taiwan and Japan, and there's been pilot studies and pilot cards that have been rolled out in BC and Quebec. And I'll talk a little bit about the BC experience in a second. And then biomarkers. So biomarkers are things in either the blood or the stool that we can check that help us predict, number one, whether or not a patient has biliary atresia, but then also, interestingly, how well the patients can do after a Kasai. So there might be sort of a prognostic value in some of these biomarkers as well. So I'll first talk about the stool cards. So this is a paper that was published recently describing the biliary atresia home screening program in British Columbia. And it's been out for the last, since 2014, so it's been about 8 years now, and so sort of they described the first 2 years of experience. So basically, the stool card was provided to newborns between 2014 and 2016. So every newborn baby went home with an information package, and inside that information package had a card, which I'll show you at the end, which has a number of different pictures of stools and a phone number to call, basically. And out of the 87,000 live births between 2014 and 2016, there were 6 patients that were eventually diagnosed with biliary atresia. And using the stool card, it actually identified, or at least prompted, 5 cases. So 5 families sought medical attention specifically as a result of looking at that stool card. Of those 5 patients, 3 were referred to a pediatric gastroenterologist. And then 2 of those families were seen by their general practitioner, but unfortunately no additional testing or referral was made. And then one of those patients, it came out that they did see that there was some abnormality in the stool, but it wasn't consistent enough to prompt the family to seek medical attention. And when they did, then a late referral was made. And so looking at the program success, so those 3 patients where they identified that the stool was abnormal and an early referral, and then a referral to a GP was made, and then they came to the attention of a pediatric gastroenterologist, the mean time to Kasai procedure was about 50 days. Whereas in those patients where the stool card did not result in a referral to the gastroenterologist, the mean time of Kasai was 116 days. So overall, it was successful in that the program that identified those patients got an early Kasai, but unfortunately half those patients didn't have successful program and therefore had the delayed Kasai procedure. So as a result of their experience over the first 2 years, BC's modified their stool card, and so this is sort of what it looks like. So basically now there's sort of a line here that says, if your stools look abnormal, so basically anything from numbers 1 through 6, then go to your family doctor or go to your doctor and request a bilirubin. And then you can see here the normal stools are stools 7 through 9. And then on the back of this card, there's a bit more information about biliary atresia. I'm quite interested to see what their experience has been now over the last 6 years or so, but definitely, very encouraging experience from the first 2 years. And as I said, Quebec is also either in the midst or have already rolled out their card recently, and so I'm sure we'll be getting more information from the Quebec experience as well. All right, so the next thing I'd like to touch on is biomarkers. And I want to bring this topic up because, the stool cards are quite important and have been proven to be helpful, but it does require a couple different steps, and it does require the parents to be engaged, but then also family doctors to be engaged, whereas sort of newborn screening can be helpful because patients can, while they're in hospital after delivery, be tested and then sort of screened in that fashion. So as long as the provider remembers to do it, then they're sort of in the system. And so this was a study done out of Texas between 2015 and 2018, and they screened about 125,000 babies over 14 hospitals in Texas. And so basically what they did was that all newborns had a heel prick test screening for something called direct hyperbilirubinemia. And we know from the literature that patients with even bilirubin over, these are American units, but in our units it would be like 17, it would be abnormal. So in patients that were screened within the first 60 hours of life, or basically before they were discharged from hospital after delivery, if they had a bilirubin greater than 1 milligram per deciliter or 17 micromoles per milliliter, which is our units, then they would be referred to a second stage test where they would be re-screened with the same test at 2 weeks. So for example, if someone screened positive, so had a bilirubin greater than 17, a direct bilirubin greater than 17 in the first 60 days of life, they would be asked to repeat the blood test at 2 weeks of life. And then they looked at, what was the time of Kasai and time of referral compared to a historical cohort before they started the screening process. So basically, they had, as I mentioned, 125,000 births, and then about 123,000 of them were screened. A significant, almost all of them had a negative screen, but there were about 1,000 that had, 1,300 that had a positive screen. And of that 1,300 with a positive screen, 20 were not retested for a number of reasons. But 99% of them were retested. And then we still had about 120 patients with a positive screen and 1,200 patients with a negative screen. So what about these 119 patients? So of those 119 patients, 7 of them had biliary atresia. So based on this type of screening protocol, it actually detected all patients with biliary atresia. So that's what the sensitivity is how good is it at picking up a test for patients with the disease. So in patients with biliary atresia, they were all picked up using this sort of screening protocol. So very, very effective. And then specificity basically means how well are you able to rule out biliary atresia? And as I said before, many of those patients, or 99% of those patients, had a negative screen, whether it's either at the beginning or at that second screen. And so, if you have, so that basically it means it's good at screening out patients that don't have biliary atresia. And then this positive predictive value means, okay, if you had a positive test at that first screen, how likely are you to have biliary atresia? And it's about 5%, whereas negative predictive value, so if you had a negative test at the beginning, how likely are you to have biliary atresia? And because this test was able to detect all patients with biliary atresia, if you had a negative screen, basically it rules out biliary atresia. So then they looked at, okay, well, based on the screening protocol, does the age of referral change? So basically, when those patients are picked up, then are they referred to a pediatric gastroenterologist any earlier? And what you can see from these charts, or this graph, is that this yellow bar is before the screening protocol, the median age at which the patients were referred to pediatric gastroenterology was about 50 days of age, whereas after the screening protocol, they were referred generally after 2 weeks. So quite a significant decrease in the lead times for these patients waiting to be seen by us. And then this is like the surgical consult, so time from first specialist encounter, so pediatric gastroenterologist, to when they get their Kasai. So this was about the same, partly because I wonder if it's because when they see a pediatric gastroenterologist and we think that it's biliary atresia, then then we generally make that referral to the surgeon quite quickly. And then this is the other thing that they looked at, is what was the age at which these patients got their Kasai. So as you can see here, before the implementation of the screening protocol, the Kasai was over 60 days of life. So sort of just after that 8-week rule of thumb, whereas after the implementation of the screening protocol, the median age of Kasai was well before that 30 days. So, definitely improved in the days in which the patient required their Kasai. And so basically this chart is just saying exactly what I just kind of went through. There was a significant difference in the patients that, the proportion of patients that underwent the Kasai procedure before sort of the 30 days. And then this normalization of bilirubin is important because, and I'll go through the study in a minute, but basically this is one of the things that we look at as pediatric liver doctors, is that after the Kasai procedure, how long does it take for your bilirubin to normalize? And if it's normal by 90 days, then you probably have a good chance that you're probably not going to need a liver transplant. Whereas if it's abnormal in 3 months, if it's still abnormal in 3 months after the Kasai procedure, then you'll probably require a liver transplant. And then this is sort of that 1 year liver transplant free. It's not statistically significant, but you can see here that 95% of the patients after the screening, implementation of the screening, did not need a liver transplant within 1 year, whereas 80% did not need it in 1 year before the screening. So, kind of like a 15% difference. So you might be wondering, well, what about those 112 other patients that screened positive on that second screen? So, about 60 or 50% of those patients, they never really found a cause of that second positive screen, and for the most part, were normal afterwards. But then that means that 50% of the remaining patients, we actually found other things. So we found either congenital infections, other types of liver disease, other genes that might be associated with liver disease. So even though these patients didn't have biliary atresia, they were still brought to our attention and potentially made a diagnosis of their non-biliary atresia liver disease earlier. So, quite an interesting study. And then so after we've made a diagnosis of biliary atresia, and then after we've implemented sort of the Kasai procedure, what do I look for, or what do pediatric gastroenterologists look for to kind of let us know if the patients are going to do well after the Kasai or not? And so, as I kind of alluded earlier, I often look at the total bilirubin after 3 months. And the reason for that is because there was a big international study that looked at this to see if this would help predict if these patients would eventually need transplants. And so this was in a big international study between 2004 and 2011. They looked at 137 patients basically across the U.S. and Canada, and they followed these patients for 2 years after the Kasai procedure. And what they found is that patients with a total bilirubin less than 34 after 3 months after the Kasai procedure actually ended up doing quite well and were unlikely to require a liver transplant, whereas patients with elevated total bilirubin greater than 30 micromoles per liter, many of those patients did require a liver transplant. And so this is sort of what we call a Kaplan-Meier curve, and this is the probability of survival. So either if they received a liver transplant or passed away, then they fall into, then they kind of go down in this probability. So you can see in the blue, these are the patients that had total bilirubin less than 34 3 months after Kasai. And as you can see here, most of these patients do quite well. And even at 2 years post-transplant, about 85% of these patients did not require a transplant or did not die. Whereas the patients that had total bilirubin greater than 34 at 2 years, you can see here that many of these patients either required a transplant or eventually passed away. As you can see here, the majority of those happened sort of within that first year of life. So the other thing is I want to talk a little bit about a special protein called MMP7. MMP7 is creating a bit more buzz because it's sort of a newly discovered biomarker that helps us diagnose biliary atresia quite well. I won't go into too much detail in terms of the diagnosis, partly because it's not that screening test is not really available mainstream yet, but I expect it to be probably in the next 5 to 10 years. But what's actually quite exciting is that it might also provide information about whether or not the patient, again, also will do well post-Kasai or not. So this was a study with 36 patients with biliary atresia. They did a MMP7 level sort of 6 months after the Kasai procedure. And then they found that patients that had an increase in MMP7 after the Kasai procedure had a higher frequency of liver transplantation compared to infants that had a decrease in MMP7 following their Kasai procedure. And you know, in this particular study, they found that MMP7 of more than 10 helps predict whether those patients would do well or not. And so basically, this is saying that MMP7 could potentially predict those at increased risk of requiring a liver transplant. And as you can see here, these are the patients, this is a probability of requiring a liver transplant. So at 100%, it's assuming that everyone has had a liver transplant, and 0% is no one with a liver transplant. As you can see here, if you had low MMP7 after your Kasai, then only about 18% of those patients required a liver transplant up to 6 years. Whereas if you're in the high MMP7 category, then up to 75% of those patients required a liver transplant. And what I thought was really interesting in this study was that there were patients sort of in this high MMP7 that actually had normal total bilirubin. So it might actually end up being a better predictor of long-term outcome or need for transplant than sort of clearance of or normalization of your total bilirubin. I appreciate that this is just one study, but I think that's quite interesting, and I think obviously we need more information to help guide us in our prognostication. But I think MMP7 is quite an interesting biomarker that we can use for both diagnosis and prognostication. And so what are the future directions? And so, as we learn more and more about biliary atresia, there are more and more sort of ideas of how maybe we can prevent the progression of biliary atresia once the diagnosis is made. And so, in the literature and in animal models, there are a number of molecules or antifibrotics or basically molecules that prevent fibrosis in the liver, and they're using these in animal studies to see whether or not it helps prevent the progression of animal models of biliary atresia. When I recently reviewed whether or not there are any clinical trials in humans with biliary atresia, one of these ASBT inhibitors, so this is it's a bile acid inhibitor in your small intestine. So I did see that there was one clinical trial in China, it looks like, looking at this specific question, whether or not these bile acid inhibitors might prevent the progression of biliary atresia. So I think very, very exciting to see what the results of those studies will be. But, absolutely, we're looking to see whether or not, after the Kasai, in those patients that, we think might not do well, is there anything we can do to prevent a future transplant? And with that, I thank your attention, and I'm happy to answer any questions at the Q&A portion of the talk.
Thank you very much, Dr. Lam, for that great talk. I think at this point, I'm going to go ahead and welcome our second presenter, who is our patient advocate, Michelle Vanderhart. Michelle lives in Alberta with her husband and 3 children. She is a country girl at heart and loves camping, playing piano, sewing, being outdoors, and reading books. Michelle's son Mason's medical journey has changed her and her family's lives. They've learned a lot through this whole process, and Michelle is here today to share that story. Michelle, over to you.
Thank you for having me and allowing me to share our family's story. So I'll start at the very beginning. Mason was born normal, full term, just like my other 2 children were. But he had this lingering jaundice that sort of never went away. I know the public health nurse was back to our house a couple of times, still checking to see if it was hanging around. Then he had an episode of pale stools. They were like almost as white as a wall, like very clay colored. He was actually with my mom, and so this alerted her, saying that I should definitely get that checked out. So I brought him to our local ER department, and they ran some blood work, did testing. Then they had immediately called up to Alberta Children's Hospital in Calgary, and the next morning, very early, we were booked in to be there to meet with the GI doctors and everybody up there. There was a lot of procedures and testing and stuff that went on once we were there. Then he was diagnosed with biliary atresia. He was 5 weeks old when he had the pale colored stools. And so he had his Kasai procedure when he was 6 weeks old. We stayed at Alberta Children's Hospital for about 4 weeks after that in hospital. After that, he had failure to thrive, a lot of puking. He was always difficult to feed. He couldn't gain weight on his own. So he had to get an NG tube at 4 months old. And he took a long time to feed every time. I remember that. It was always a struggle for him to get a few ounces of formula down. He had low muscle tone. It took him longer than my other children to learn to sit, to crawl. He was hospitalized a number of times, a couple of times with cholangitis, which is an infection that he's prone to getting because of the connection that had to be made in the Kasai procedure. He also developed ascites in his abdomen, which is a collection of fluid. So he had to get that drained one time, and then it was controlled with diuretics after that. Also, at about age 2 or 3, he was diagnosed with EOE, or eosinophilic esophagitis. We actually found that by chance. He was getting a routine endoscopy, checking for varices, which is another complication of biliary atresia. And the doctor found white lines in his esophagus, and there was inflammation there. And so then they did a biopsy and found out that he also had EOE. We were able to determine that the trigger for Mason was gluten. So we ruled that out of his diet. It was also controlled with a fluticasone inhaled steroid. Then towards the end of 2021, he was having a lot more complications from his liver disease. He had minor varices developing. He had the ascites, portal hypertension. And so in 2000, like this year, 2022, Dr. Lam had recommended that we get assessed. So we were referred to Edmonton. And we got assessed in February, and that was when he got listed on the transplant list. So he was 6 years old when he got listed. We were just going through the whole living donor process to determine if my husband or myself could donate a part of our liver to Mason. And then we got the call on May 14. So he was transplanted May 15 of this year. It was a very, very long surgery. It was about an 11-hour wait with no interaction with anybody, wondering what was going on. But after that, he stayed in the ICU for a little over 2 weeks. He had a lot of pain. There was a little other complication during transplant. They had to remove a part of his bowel as well because they couldn't get his old liver out. It was so scarred in place. So he had what they call ileus, or the process of the bowels trying to start up again and get working. So there was a lot of pain from that, and it is a slow process to get that going again. We were in hospital at the Stollery in Edmonton for about 6.5 weeks. Then we were graduated to the community of Edmonton. We had to come back often for checkups and appointments, but we were allowed to stay in the city of Edmonton. That was for about 2.5 months, and then we were allowed to transition home, and then we went under Dr. Lam's care once again in Calgary. And so now we are about 4.5 months post-transplant. We're just starting to wean off some of the medications that he had to be on after transplant. So he struggled with a virus after transplant as well. They're not sure if he caught it before, during, or after the transplant surgery, but that took several weeks because he was immune suppressed now, and so it took a long time for the virus to clear out. He also has had one episode of rejection. That was while we were in Edmonton. Currently, he's still on about 7 different medications, but we're working on weaning some of those as we go further and further out. He still has feeding struggles. That is most of our problems now. Still has the NG tube, gets formula feeds 4 times a day. He does eat some orally on his own, mostly just snacks though. He has many food aversions. Currently, he is going to school, grade 1, so he's transitioned back to school. And other than that, he's very active, like all other 7-year-old kids. He runs around just like all the rest of them, and we've noticed much more energy now post-transplant. Before, he had struggled a lot with fatigue. It was hard for him to get through a school day, and now he has much more energy to get through it. So that's basically Mason's life story and our families.
Thank you very much, Michelle, for sharing your story. It's still very fresh for you. You're still in it. So
Yeah.
I really appreciate that. I would just like to invite our speakers to join us back again on camera. Dr. Lamb, for a short question and answer period. So if anyone has any of those, feel free to put them in the chat box.
Yeah, well, I'll just ask one question if possible for Michelle. I guess generally, you were able to learn about the condition probably throughout this journey as everything was going on. What would you say was, I guess, some of the main challenges with the force balancing life and family and other children as well, but also trying to figure out how to learn about this condition? Was it primarily through kind of online searches or speaking with the healthcare providers, or kind of all at once? Just for some of those parents who are tuning in who may be lost once they obtain a diagnosis initially.
It was mostly, yeah, through the GI doctors at Alberta Children's. I know at first you're just bombarded with all of this crazy medical information, and it is a lot to take in and process, but that is mostly how we learned about. Of course, you Google things, but it's never that accurate than actually talking to your own doctors that know your patient. So.
Perfect, thank you. I believe we have a question here in the chat box. It's from Michelle as well. Aside from the fatigue, are there any other changes you've noticed in Mason post-transplant?
Yeah, the number one thing was the energy. Even all the teachers at school have commented too that he's just way more energetic than he used to be. Other things were his skin looked a lot clearer, like not as yellow. He was always a bit yellow. And his eyes also. Now, after transplant, we can look in his eyes and they're clear white eyes. We had never seen that on him before. So those are the biggest changes.
I guess, Dr. Lam, if you don't mind kind of maybe jumping in and see if there's anything else is that pretty much common for most of the patients that you've seen as well, or do you spot some differences?
Yeah, I mean, I think, everyone's experience is a little bit different, but I mean, I would echo Michelle. I think, Mason looks great. Like, I think, as the energy, is definitely one of the first things to come back. And then I think part of it too is the kids often feel like way better. And so then they're able to learn at school, they're able to play with their friends, they're able to sleep better at night, those types of things. So I think all those things also contribute to just sort of overall well-being, and then being able to participate in a number of other things. The other thing that I've definitely noticed in a number of patients is that, often nutrition is a huge part of liver disease, and, in kids we're often trying to optimize nutrition in patients with chronic liver disease, because, eventually if they need a transplant, the way that I've sort of described it is, the stronger you go in, the stronger you come out. And so we definitely want to make our kids go into those, huge surgeries as strong as possible. But then also, while we're sort of waiting for that to happen, we still need to provide enough calories for them to grow appropriately. So, as Michelle has highlighted, that, nutrition and growth is often one of the main challenges in pediatric liver disease. And so often we find that after the transplant, these patients do have a lot of catch-up growth. So, whether they get taller or sort of fill in a little bit more, we definitely see that.
Great, thank you. I guess one question that we often get as well at the foundation was respect to, I guess, those individuals with biliary atresia who don't get a transplant. Is there differences between the overall survival rate, or those who actually long-term outcomes, and perhaps how long relative to the individuals who are able to receive a transplant at an earlier age, such as Michelle's son?
Yeah, I mean, that's a great question. I think that one's a little bit tricky to answer. But I guess the way that I think about it, and the way that I sort of explain it to patients, is that, the data tells us that for biliary atresia, 80% of those patients will require transplant before 18 years of life. So basically that means, the large proportion of our pediatric patients will require transplant at some point in their sort of pediatric years with us. Most of that, actually, the 50% of that usually happens within the first 2 years of life. So basically, 80% of pediatric patients will eventually get a transplant within that sort of pediatric age range, which means that 20% don't. And so, within that 20% that eventually go into adulthood, I don't know that there's good numbers to tell you how many of those will eventually progress to transplant. But I would imagine that that number is relatively low because, the indications for transplant, when you're doing that well, if you kind of get to that 18 years of age, you're probably not going to need a liver transplant if it's kind of straightforward biliary atresia. If you're having a ton of infections or whatever, that might be a little bit different. And then in terms of survival, we know that patients that are transplanted for biliary atresia, I expect them to do very, very well. And, we have patients, sort of into their 40s and 50s that have been transplanted sort of, a while back, and their livers are doing well. So, in my mind, I have every reason to believe that those patients that get transplanted early will do very well, and then those patients that don't need a liver transplant because the livers are healthy, will do very well as well.
Oh, perfect, thank you. Actually, we'll have Michelle one more question here for you. Kind of a general question in terms of the emotional aspect. So it's how do you, Mason, and your family deal with the emotional aspect of going through this experience? And perhaps what resources do you find helpful through this journey? So I know you touched on some of the information from the healthcare providers in the hospital you received. Anything else in terms of emotional aspect or emotional resources that you found helpful, and maybe perhaps how you cope or manage to this day with everything that's going on?
Yeah, I will not sit here and say that it is easy. It is a hard journey, and it's hard for the whole family also. How we dealt with it, counseling. I've gone through counseling. My husband has. All three of my kids have seen counselors at different stages. Just having supportive friends around you, family. My parents are super close to us, so they were pretty much mom and dad to my girls for a lot of their life because we were away with Mason in hospital multiple times. So having, supportive people around you. Our faith has been huge to us. We have quite a large church family also behind us. So having that support and help was also huge through that journey. Yeah.
Perfect, thank you for that. We'll ask one more question here, Dr. Lam, in terms of some of the other common conditions, or perhaps some of the other uncommon genetic conditions that are affecting children, perhaps young children or a little older children. We get some questions on Wilson disease, and we get some questions on LALD, or lysosomic acid lipase deficiency. Perhaps you could touch on Wilson disease in terms of children. We just highlighted what the condition is for those of the audience members who aren't really familiar with it, and perhaps if it's inherited, how it's inherited, and outlook on life. And then we can chat about the LALD as well in terms of that aspect as well.
Yeah, for sure. So for Wilson's disease, it's an autosomal recessive condition, meaning that you have to have mutations in both copies of the gene. And the gene is responsible for copper metabolism, and it's responsible for the pump that helps remove copper or gets rid of copper from the liver, and it gets excreted sort of into the bile. So when you have two mutations of that gene, then your liver can't remove copper and excrete it into the bile, so then the copper sort of builds up inside your liver. And then so when that copper builds up inside your liver, it can cause liver irritation, inflammation, and then eventually scarring. Sometimes that copper can leak out of the liver and in your bloodstream, and it can deposit or kind of end up in other places. So other common places are sort of like in the brain or in the eyes and that type of thing. So, it's relatively rare, but, we do see it from time to time. You know, the way that it's often picked up is either through, you know, routine screening where a patient has blood work for whatever reason, the liver numbers are high, and then they get referred to us and we sort of do the workup and we find that. But a lot of our patients are actually diagnosed through screening family members of a patient with Wilson's disease. So for example, you know, if someone comes to us with elevated liver enzymes and we find out that they have Wilson's disease, because they come from the same family and they probably have some variation of the same genes, then they're at increased risk of having those two same mutations. And so in patients where we make a genetic diagnosis of Wilson's disease, we'll often screen other siblings to see if they have that same mutation. But, you know, once we make the diagnosis, then depending on the liver numbers, depending on the copper numbers, that type of thing, then we're able to decide, okay, well, what sort of therapy is the next step? So do they need to take medicine to help remove the copper from the liver? Or are we okay just providing medication that helps prevent excess absorption or intake of copper? So it is patient dependent, and it really depends on a number of other factors. But for sure, you know, it's something that we frequently look for, but generally is pretty rare. And then you mentioned LWLD, which is lysosomal acid lipase deficiency. You know, that's also incredibly rare, but it is, you know, something that we can screen for as well. So I often think about LWLD in a pediatric patient that gets referred to me for, you know, sometimes what they think is, what the person's referring to me for non-alcoholic fatty liver disease. So this is a patient that generally is quite young and for whatever reason has had ultrasounds or liver tests, which has led to an ultrasound, and they look like they have, you know, fat inside their liver. And so in a patient that doesn't have the typical risk factors for fat in the liver, then that's sort of when I would start thinking about, okay, well, LWLD, and then I would send some genetic testing for it. But to be totally honest, you know, it's an incredibly rare disease. But with that being said, you know, there are therapies for it. So if there is a patient that's diagnosed with LWLD, then, you know, there is medication that we can do, that we can use to help prevent the complications of that disease.
Perfect. Thank you. Thank you for those. I think we'll end the Q&A for now. We can come back to Carrie going through the breakout room session. We may probably split the breakout rooms into two, maybe a little larger groups, depending on how many folks we have. So we'll probably have choices between two groups, and we can come back and discuss some final questions in about 15 minutes, but I'll let Carrie take over.
Thank you, Nam. Just a quick minute to say again a really heartfelt thank you to our speakers today, Dr. Lam and Michelle. Really shed some light on the topics here. As mentioned, this session will be available on the CLF Living with Liver Disease webpage. That's www.liver.ca/LWLD, and our YouTube channel, and it'll be there over the next few days. Join us for our next session in October on liver cancer and tumors. For more information on upcoming sessions and to register, please visit that liver.ca/LWLD page at the start of each month. If you don't see the session posted yet, or there's minimal information, please do check again in a few weeks, as they're probably just finalizing speakers. We're now going to go into those breakout rooms we spoke of. At the bottom of your screen, you'll see a button that says breakout room. Please click the button and give it a few seconds before you see the different groups available. As Nem mentioned, we'll probably break into two, so we'll do Eastern Canada and Western Canada. Once again, we suggest you join that group within your geographical region. Give us a few seconds to get the room set up. Once you see the groups on the screen, go ahead and click join on the right. If at any point you need to leave the room, simply close the room or the meeting. And Dr. Lam and And Michelle, if you'd like to join the Western Canada room first, and then we'll slide you on over. Okay, well, if we all made our way back over here, I want to thank everyone for participating in the peer-to-peer breakout rooms and for attending today's Living with Liver Disease session on children's liver disease. Should you have any additional questions or comments, or simply want to stay up to date on everything liver health related, please connect with us via our social media channels highlighted on the screen, and or send us an email at clf@liver.ca. Thank you to our sponsors. And of course, a big thank you to those who attended tonight. And once again, thank you to Dr. Lamb and to Michelle for all your wonderful insights. It's really great to hear from you.